We finally arrived at malaria, the last of the Apicomplexan diseases, and perhaps the most famous one. The incubation period is highly variable and ranges from a week to a month or more. There is usually a fever with chills, headaches, muscle, and joint aches, as well as weakness, vomiting, and diarrhea. Fevers cycle every 2 or 3 days, and this correlates to different malaria parasite species. Some types of malaria may rapidly progress to a severe, sometimes fatal stage in less than 24 hours, which may involve the central nervous system, resulting in a coma in cerebral malaria, or splenomegaly may occur with a ruptured spleen in rare cases. Anemia, which may be severe during pregnancy, may also be present. Acute respiratory distress syndrome in pulmonary cases may occur, as well as renal dysfunction with acute renal failure. There are 4 main species of the malaria parasite that are human pathogens: Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, and Plasmodium malariae. Plasmodium vivax and Plasmodium ovale infections are not as deadly, although there may be additional attacks or relapses months or even years later after becoming symptom-free. This is due to the dormant liver stage parasites, also called hypnozoites, that may reactivate. Treatment is needed to reduce these relapses. In comparison, Plasmodium falciparum infections can be life-threatening, as some of these clinical manifestations may occur: severe anemia due to the lysis of infected red blood cells, hemoglobin in urine resulting in a condition known as black water fever, adherence of infected erythrocytes or red blood cells to the vascular endothelium of blood vessel walls that do not freely circulate in the blood, blocks the capillaries in cerebral malaria, resulting in high mortality rates and kidney involvement and failure. Severe Plasmodium falciparum malaria infections may have a mortality rate of 20% or higher. The life cycle of malaria is rather complicated. Let's look first at the mosquito stage on the left with the red arrows. Male and female gametes, originally from the blood meal of an infected human, fertilize in the mosquito midgut and form zygotes, which develop into oocynates and then oocysts. Sporozoites are released from oocysts and travel to the mosquito's salivary glands, where they are injected into the bloodstream of a susceptible human during the mosquito's next blood meal. They travel to the liver, maturing into schizons. Merozoites are released from mature schizons and infect red blood cells. They develop into trophozoites, which reproduce asexually by maturing into schizons that are filled with merozoites. These merozoites are released to infect more red blood cells. Occasionally, some trophozoites develop into gametocytes, which are the sexual stages of the parasite, and there are male and female forms. These are taken up by the mosquito in blood meals and become gametes, which fertilize to perpetuate the life cycle. Malaria is a disease that is endemic in tropical and subtropical parts of the world, at altitudes below 1,500 meters, where Anopheles mosquitoes can survive and multiply, and the malaria parasite can complete its growth cycle in mosquitoes. Temperature is critical, as Plasmodium falciparum cannot complete its growth cycle in the Anopheles mosquito below 20 degrees Celsius or 68 degrees Fahrenheit, and therefore transmission is absent in cooler temperate regions or seasonal during warmer summer months. Instead, another malaria species, Plasmodium vivax, is more prevalent in these parts of the world, as it is more tolerant of lower ambient temperatures. Different species of malaria that are pathogenic to humans are found in different parts of the world: Plasmodium falciparum and Plasmodium vivax in Asia and Africa, Plasmodium ovale in sub-Saharan Africa, and Plasmodium malariae in South America, Asia, and Africa. Recently, a new zoonotic species was identified. A human case of Plasmodium knowlesi, which infects primates such as baboons and other monkeys, was reported in Southeast Asia. In 2018, there were 228 million cases and more than 400,000 deaths from malaria, more than two-thirds in young children below the age of 5, mainly in the WHO African region. Risk factors include travel to endemic areas, in particular sub-Saharan Africa, where there is the greatest risk of both getting malaria and dying from the infection, South and Southeast Asia, South and Central America, and the Caribbean, and Papua New Guinea and other small islands in the South Pacific. Women who are pregnant or likely to become pregnant should avoid travel to malaria endemic areas. The map shows the distribution of malaria in the world. Burgundy indicates elevated occurrence of chloroquine or multi-resistant malaria. Red, the occurrence of chloroquine-resistant malaria. Brown, no Plasmodium falciparum or chloroquine-resistant malaria. And gray, no malaria at all. The incidence rate of malaria in Canada has remained quite stable over the past 10 years, and the national and provincial rates hover between 1 and 2 cases per 100,000 population. It is slightly higher in Toronto, but this has decreased in the past 4 years. From a Toronto public health investigation, the last of which was in 2016, travel abroad was associated with the majority of the cases, with travel to Nigeria being the highest, more than a quarter of the cases, then 2 other African countries, and India, although the list of countries varies from year to year. Diagnosis of malaria is by detection and identification of the parasites in blood smears using microscopy. A histological stain is used to stain the parasites, and both thick and thin smears are prepared. The thick smear is for detecting presence of parasites, and the thin smear is for identifying the different malaria species. You can see a thin smear or film and a thick smear on the microscope slide in the picture after staining. The asexual stages are found in red blood cells as ring-formed trophozoites originally. These ring forms usually have dense chromatin dots. You can see the ring forms for Plasmodium vivax and Plasmodium falciparum in the picture. They look quite similar, so it is difficult to distinguish them at this stage. It is the sexual stages that have distinct morphological differences between species, which enable speciation by microscopy. Plasmodium falciparum gametocytes are crescent-shaped, whereas Plasmodium vivax gametocytes are round. Treatment depends on many factors, including the disease severity, the species of malaria parasite causing the infection, and where the infection was acquired. There are a selection of antimalarials for the different types of drug-resistant or sensitive strains of malaria present around the world. The first line of drugs are the older ones such as the quinine-based ones, and the second line ones are the artemisinin derivatives for chloroquine and mefloquine-resistant malaria strains. Some drugs are effective against the dormant liver forms that are present in certain types of malaria such as vivax malaria. However, this drug is not suitable for pregnant women or individuals with glucose 6-phosphate dehydrogenase deficiency, which is a genetic trait that is protective against malaria infections. Treatment is necessary when fever occurs in a traveler within 3 months of returning from a malaria endemic area, as this is regarded as a medical emergency, which should be investigated urgently with thick and thin smears for malaria. Although we are not training to be physicians, if this occurs in the community and the health unit is approached, it is always essential to ascertain travel histories and then refer these individuals to healthcare professionals. Due to its life-threatening nature, severe P. falciparum malaria infections require immediate hospitalization and urgent intensive medical management. There are a number of drugs available for treating severe and cerebral malaria and alternatives as well. These medications are only available in Canada through the Canadian Malaria Network. There are 13 medical centers across Canada. Major problems with treatment include increasing drug resistance and also severe side effects. Plasmodium falciparum resistance to earlier generation antimalarials such as chloroquine is widespread. Malaria parasites that are developing resistance to new artemisinins are also starting to emerge in Southeast Asia and parts of Africa, which is worrisome. Different prevention strategies are used in endemic areas, including insecticide-treated bed nets, intermittent preventive treatment of malaria in pregnant women and in infancy, indoor residual spraying, larval control and other vector control interventions, and mass drug administration and fever treatment, which I've provided links to so you can all get further information on them if you need them. There were no malaria vaccines for the longest of time, but now we have a new one called RTSS. It is the most advanced vaccine as it has completed all its clinical trials and is now being used as part of the childhood vaccination programs in 3 different African countries. 275,000 children have received the vaccine in the past year. During the clinical trials, it was ascertained that there was a significant reduction of clinical and severe malaria in children between the ages of 5 to 17 months in 7 sub-Saharan African countries. However, vaccine efficacy was lower in other age groups. For Canadian travelers, the recommendation is to avoid rural and remote areas in endemic regions, and to reduce their risk by taking protective measures from mosquito bites. Also, to use chemoprophylaxis, that is, anti-malarial medication. Travelers should consult a healthcare provider or visit a travel health clinic, preferably 6 weeks before departure, to discuss their risks, determine whether to take anti-malarial medication, and if so, which one. No anti-malarial medication is 100% effective in preventing disease. So, the Government of Canada advises several strategies, and these are called the ABCD of malaria prevention, which we'll see on the next slide. The ABCD of malaria prevention is: be aware of malaria risks, symptoms, and how long they take to appear. Know how to prevent mosquito bites. Protect yourself from mosquito bites, particularly from sunset to sunrise. Take anti-malarial drugs or chemoprophylaxis if appropriate. The medication needs to be taken until it is finished, even after returning to Canada. Seek medical help early for diagnosis if malaria-like symptoms develop. Know the symptoms of malaria and seek medical attention immediately if a fever arises during or for up to a year after travel to regions at risk of malaria. Be sure to tell your healthcare provider that you have traveled to a region where malaria is present.